Hello and welcome to the video on correcting ventilation abnormalities and looking at permissive hypercapnia or hypercarbia. These are pretty big important subjects when we talk about it. We've practiced some of this stuff already in lab. So when we're talking about this, try to take it slow, one step at a time. Don't hesitate to pause and write down your notes, and we'll go from there. So let's get started. All right, so what abnormalities can we be looking at? One of the big things that we have to pay attention to is just go ahead and get an arterial blood gas. And we're talking adult patient population here. Getting an initial arterial blood gas, and like I said, within that first 30 to 60 minutes, you want to make sure you've documented, you've changed things, you've looked at things. That arterial blood gas tells us about ventilation and oxygenation and pH balance. So it'll give us a lot of important information, but the big thing is to key off of the pH, right? So when I'm looking at a blood gas, is the pH basic or acidic, right? So is this patient now in an alkalosis when they were in an acidosis first, or are we way off from where they should be with their pH balance? So that's the first thing that we're going to be looking at, is keying off of that pH. Then we're going to look at how well they're ventilating by checking the PaCO2. That's right, PaCO2. Right, so that's going to tell us about ventilation. So if a doctor's asking about their CO2 level, they're evaluating their effectiveness of ventilation. How well is the ventilator doing? Do we need to make adjustments there? And this is what you should be looking at too, right? Should I make some suggestions or make some changes based upon that PaCO2 level? And then evaluate oxygenation by looking at saturation, SaO2, and pressure, P(a)O2. So saturation and PaO2. Saturation and PaO2. We'll look at oxygenation on this patient. Saturation and PaO2. So those are good way, because saturation tells us how much oxygen is on the hemoglobin, and it does the bulk of carrying. And then PaO2 is the pressure of oxygen in your blood plasma. So it tells us about that pressure gradient, and if we're able to get enough pressure gradient to help with diffusion to the tissues. So both of those are important to evaluate, and we'll talk a little bit about the oxyhemoglobin dissociation curve in here. But if you need a refresher on the oxyhemoglobin dissociation curve, I have another video on that, and so if you want more information, please seek that out. All right, the CaO2 here, right? Content of arterial oxygenation looks at the best way to evaluate oxygenation. This one looks at the best way to evaluate oxygenation. This is even on the boards, right? They'll ask you, which of the following is the best way to evaluate oxygenation? They'll say saturation. They'll say pressure. They'll give you some other random answer, right? You're going to pick CaO2 because you're combining what's on the hemoglobin with what's in the plasma. So you're combining the saturation of oxygen with the PaO2 to figure out someone's total arterial content. So CaO2 is king of evaluating saturation. It's king of evaluating oxygen saturation. So if you ever ask that in the future, what's the best way to look at someone's oxygenation? We're going to look at CO2 because it combines both pressure in the plasma and what's on the hemoglobin molecule. And those are the only two ways oxygen is carried. So when we combine those two, it's the best of all worlds, right, to look at that. The DO2, which is this next one here, the DO2 is the delivery of oxygen, and it looks at both the total content, so you're going to take the CO2 times 10, and then you're going to multiply that by the cardiac output. And this looks at how well we can deliver the oxygen. So that's why it includes that cardiac output in it. We're going to take the CO2, which is the one just above that there. We're going to take that CO2, we're going to do a conversion, and then we're going to multiply it by the cardiac output. Because how does the oxygen get to the tissues? How does it get delivered to the tissues? Well, it just doesn't magically float there. It's delivered by the cardiovascular system. And that's where the DO2 becomes very handy, because now we're looking at total content, which is the best of both worlds, and how that total content gets delivered. So that's DO2, right? And so if someone's DO2 is low and their content is good, well, it's a cardiovascular issue, right? And so that DO2 looks at both oxygen content in the artery and how well we can deliver it. So that's something that you can be very helpful with when we're trying to see why a patient's not getting good oxygen delivered to their tissues. Well, is it the heart, or is it how much oxygen is getting into their bloodstream? The DO2 can be used with a VBG to look at cardiac performance, right? Ask me how. I can go on a whole video about that. Very, very long video. But the big thing here is if minute ventilation stays the same, if there's no dead space changes or anything like that, if everything's the same, and we're on a ventilator and the metabolic rate hasn't changed, right? So metabolic rate is constant, minute ventilation is constant, and our venous saturation decreases, then that's a sign that our cardiac output has decreased. So once again, assuming assuming a stable minute ventilation, assuming a stable metabolism, if my VBG, if my venous saturation from a central line starts to decrease, then I know it's my cardiac performance that's decreasing. And so all that's based upon the DO2 because, hey, if my delivery is the same, but somehow my saturation goes down in my venous side, then that means the tissue's extracted more oxygen than what was going by there before. And if there isn't a change in the metabolic rate, then it's because there's less blood being delivered to the tissue and therefore less oxygen is left over in the bloodstream, and that's how we can tell. So it's a really cool way of getting a VBG and trending those venous saturations to look at cardiac performance as well. Interesting stuff there. But when you're asking, Derek, I don't see preceptors calculate much at all. Why do I need to know this? Well, once you know the components, right, knowing the equations, knowing the components that go into this, it's shorthand for knowing the physiology, just like the DO2. Knowing that as less blood flow is delivered, more oxygen gets pulled out, even though the metabolic rate didn't change, well, that's going to help you understand physiology, then understand that, hey, because their venous saturation is dropping and everything else stayed the same, their metabolic rate stayed the same, they're not running a fever or anything like that. Their ventilation stayed the same, so that's normal. The only thing that changed would be the DO2 calculation, which would be the cardiovascular performance, which would tell you, hey, this is the heart. So even though they may not calculate it out there, they are making these physiology adjustments. So even though we don't numerically calculate these at the bedside all the time, we still use that concept. And the better you understand the equations, the better you'll understand physiology. I'll repeat that again. The better you understand equations, the better you understand the physiology, and you'll be able to make those adjustments. So it's not necessarily about the numerical calculations as much sometimes as it is about knowing the physiology and what impacts what, right? What impacts the other, the cause and effect. That's where the equations really can be very helpful, and that's why you may not see your preceptors or people at the hospital use as many calculations, because they understand that physiology relationship. They have that physiology down. But you just learning this, trying to get the physiology down, you need to know that equation because it's shorthand for physiology. All right, methods to improve ventilation and oxygen and to improve oxygenation are reviewed in chapter 13. So if you want to take a look at that, you can go ahead and do so. But we're going to talk primarily about methods to improve ventilation here. So ventilation is measured by the PaCO2 off the arterial blood gas, and it's altered by your minute ventilation. So that's your respiratory rate times your tidal volume. Your physiological dead space. So physiological dead space is an umbrella term, which includes both alveolar and anatomic dead space. So we all have anatomic dead space. Your trachea, it has gas in there that moves, but it doesn't participate in gas exchange like CO2 for O2, right? So your trachea is dead space. Your oral pharynx is dead space. Your laryngopharynx is dead space. Your main stem bronchi are dead space. So everything in the tracheobronchial tree is dead space. So we all have some anatomic dead space, and the normal anatomic dead space is 1 ml per pound of ideal body weight there. So that's anatomic. Well, then we have what's known as alveolar dead space. Alveolar dead space, if someone's lungs are hyperinflated, and let me draw one of these fancy pictures here. If I have someone's lungs that are hyperinflated, what's going to happen to the blood vessel that's surrounding the outside of the alveoli when that lung gets hyperinflated? It's going to get squished, right? So that lung is going to expand. It's going to squish that capillary. Well, is that capillary getting perfusion anymore if it's been so constricted? No, right? Because it's being constricted from the hyperexpansion of that alveoli. So therefore, we have ventilation without perfusion, which is the definition of dead space. And so physiological dead space includes anatomic, right? Your trachea, your main stem bronchi, and alveolar dead space. And when both of those are put together, we call it physiological dead space. Yeah. So if you have an increase in dead space, whether it's something like too big of lung volumes or too much positive end expiratory pressure or so on and so forth, that can easily, or poor right-sided heart failure where you're not getting enough blood to go to the lungs in the first place, or a pulmonary emboli, right? Things like that that increase alveolar dead space can really impact your ability to exchange CO2 for oxygen. So that's something that we need to look at when we're looking at their CO2 levels. And then finally, CO2 production. CO2 production here, traditionally we're looking at metabolic conditions that can cause CO2 production. And so that's something to pay attention to. Are they running a fever? Are they having active seizures, tremors, things like that that can increase that CO2 production? And infection, right? Infection's a big one there, right? You're producing more CO2 with that type of situation. So we got to understand, are those things part of this situation? So keep this in mind when we're talking about the CO2 production and ventilation. Airway burns. What would burning the airways do to your physiological dead space? What would an infection do to your CO2 production? What would seizures do to your CO2 production? What would exercise when the patient's being moved around, or when they're participating in physical activity with a physical therapist or an occupational therapist? How would that do that? Or even with nutrition, what type of substrates are we giving the patient that could increase the CO2 production, right? Are we doing a higher concentration of protein compared to lipids, or are we doing more lipids that would increase CO2 production, right? So those things can alter that as well and make it harder for us to manage CO2 with mechanical ventilation. So here is a little diagram that looks at the factors that affect partial pressure of CO2. So during mechanical ventilation, your carbon dioxide production, alveolar minute ventilation, regular minute ventilation, your dead space ventilation, your tidal volume, inspiratory time, right? Here's your inspiratory time, your expiratory time, your breath rate, right? Your frequency there. These are all things that will affect your CO2. So when we're looking at how to help these patients that have high CO2s, it could either be that CO2 production or that a minute ventilation component. And traditionally, we're going to focus in on this minute ventilation component from the ventilator standpoint. Now, the CO2 production, that's not something we can change from the ventilator standpoint too much, right? We can reduce work of breathing, things like that. But that CO2 production is something we can look at with our registered dietitians. We can look at and see if it's a substrate issue, or we could see if it's a metabolic issue, if they have an infection, things like that. So we could look at treating the CO2 production. Or traditionally, when we're trying to troubleshoot these patients, we're going to be manipulating their tidal volume, the rate, their I time, their E time, some sort of alveolar minute ventilation to help them get better CO2 elimination traditionally. So how do we make changes based upon the CO2 level and the pH? Well, here's the calculation here. Do you see it here? This is one of your favorite best friend calculations in mechanical ventilation. The known CO2 by the known minute ventilation over the desired CO2. So when we're looking at this, we can really see ultimately what we need to change their minute ventilation to in order to get our desired pH. So changing minute ventilation is common after we place someone on a ventilator, so don't think it's not. Using full ventilator support initially is what we try to do, especially if we do RSI, where we paralyze patients initially, or sedation is stronger usually during some of those situations. So you may have to use full support initially. After we get that initial blood gas, we're going to make our assessment, right? We're going to look at their vital signs. We're going to look at their lung compliance, their air resistance, right? We're going to do our whole assessment on the patient, make sure they got adequate humidity, everything in there. So when we're adjusting these patients based upon the blood gas, we usually adjust the rate or tidal volume are the most common things. So most patients, pediatric through adults, are placed on volume ventilation, right? Volume, either volume control ventilation or volume targeted ventilation. So adjusting the rate or targeted tidal volume are the most common ways to do this. So when we're looking at this equation, we can take their actual CO2, and let's say their CO2 is high, times their actual minute ventilation, and then we put it over our desired minute ventilation, and then we can actually see what we need to do to change our rate or tidal volume to get there. And we've already practiced this in the lab, so this is nothing new to you. Physiological dead space, I've previewed it a little bit. We start assuming physiological dead space and metabolic CO2 production are constant with our patients. However, understand that if we do have something that increases dead space, like hyperinflation of the alveoli, right, that would increase dead space, or poor perfusion, for some reason if they started going into heart failure or cor pulmonale, or they were hemorrhaging, right, so low blood volume, that's going to increase physiological dead space. So that can change, but most of the time we're just going to assume physiologic dead space and metabolic CO2 production are constant when we're making vent changes. But understand too, right, if that changes, that can change because their baseline CO2 production can change as well. If alveolar ventilation is low, then we can modify tidal volume to get our desired alveolar volume and thus alveolar minute ventilation. So we can increase our rate or frequency, may not change or improve alveolar minute ventilation, because if they're breathing too shallow, if they have a high dead space to tidal volume ratio, if they're breathing too shallow, rapid and shallow, if I just go up on the rapid of the breathing, but I don't change the shallowness of the breathing, then that's not going to help their alveolar minute ventilation. Their regular minute ventilation looks good, but how much of that actually got to the alveoli, got gas into and out of the alveoli? Well, hardly anything, right? So sometimes increasing respiratory rate may not make much of a difference on the PaCO2. So if their alveolar minute ventilation is low, going up on the rate may not improve alveolar minute ventilation. So we have to go up in that situation on the tidal volume. So how do we know what tidal volume to go up to, right? Do we just take a guess and just start punching numbers in there? No, this is life support. We have a better way of doing it. To define the desired tidal volume, we're going to use the equation. We're going to get our known CO2 times our known tidal volume. So we take our known tidal volume and our known CO2 and divide it over our desired CO2 to get to our desired tidal volume, right? That's this equation right here. So that's how we get to our desired tidal volume. So if you need to, if for some reason we think that that tidal volume is deep enough to have that, we can modify that equation, pretty much the same equation. We're just changing that factor to frequency. Instead of desired tidal volume, we're looking at desired frequency of breathing. So we'll take our known CO2 times our known respiratory rate over our desired CO2 to give us our new respiratory rate that we need to change it to get that proper ventilation. But just understand, if there's a shallow breath that we're already giving the patient already, increasing that rate may not increase that alveolar minute ventilation. It may not cause that CO2 to go down if they're in a respiratory acidosis. So speaking of respiratory acidosis, when the patient has a PaCO2 above 45 on someone that has non-CO2 retaining tendencies, right? So we're talking about a non-CO2 retainer lung disease. So assuming that normal lung pathology, that non-chronic lung pathology, when their CO2 is greater than 45 and the pH is less than 735, then we have a respiratory acidosis and our minute ventilation is inadequate. We're not cutting it, right? That's not working for the patient. So what are some causes of this? Well, it could be lung problems like pulmonary edema or pneumonia that's in the respiratory zone, or it could be an airway disease problem that's attacking the lungs like bronchospasm with an asthma attack, or it could be a pleural effusion that's squishing the lungs causing a restrictive effect. It could be a chest wall abnormality that's squishing the lungs causing that effect. It could be a neuromuscular injury that's not allowing the lungs to ventilate because of poor ventilation or poor muscle contractility, or it could even be the brain not telling them to breathe, like with a drug overdose. So there's lots of situations that can cause that. So when we see this, first of all, can we treat the underlying cause, right? Can we treat the underlying cause? If we find and treat the underlying cause, we're looking good. But in the meantime, we need to increase their minute ventilation some way, somehow. But if we have that known cause, if we know that there is a massive pleural effusion, for example, then why don't we get a thoracentesis, or why don't we get a chest tube and get that taken care of? And that should help with the respiratory acidosis without us just going up on the ventilator, right? So in the meantime, we could go up on the ventilator minute ventilation, but let's treat the underlying cause so that way we actually don't have to have that patient on such high settings for a prolonged period of time. With a respiratory acidosis, how do we correct it? Well, we're going to correct it by adjusting the tidal volume or the rate to achieve their desired minute ventilation. So no matter the mode, when we're increasing the minute ventilation, we're going to decrease the CO2 traditionally. But just understand that may not be linear in patients that are already breathing shallow, so poor alveolar minute ventilation. So here, when you're looking at this statement, we're assuming that keeps into mind that we're talking about alveolar minute ventilation there, right? If we increase alveolar minute ventilation, we'll decrease CO2, right? No matter what mode. So traditionally, when we put people on a ventilator, we're going to target them around 6 to 8 mLs per kilo of ideal body weight, while keeping the plateau pressures less than, I can hear some of you say it in my spirit, 30 centimeters of water, right? 30 centimeters of water, right? So we try to keep that plateau less than 30 centimeters of water. That's safe for the respiratory zone. So that's the ideal there. So if we put them on a ventilator at 7 mLs per kilo of ideal body weight, and we check a plateau pressure, an inspiratory pause, if you will, and their plateau pressure is 35, well, we need to take their tidal volume down because that plateau pressure is too high, and it's causing a ventilator-induced lung injury. So tidal volume and rate adjustments are based upon pulmonary pathology, and that's what we're going to see. We need to decrease that tidal volume if we're above 30, so that's something we're going to have to do, and then we might have to go up on the rate to continue some of that minute ventilation. If the tidal volume is at the upper limit of 6 to 8 mLs per kilo and the plateau pressure is greater than 30, right? Put 30 in there. Decrease the tidal volume to achieve a lower plateau pressure. Right? So that's where you're going to start. If you got them on 8 mLs per kilo, then go to 7 mLs per kilo. Check a plateau pressure once you're on 7 mLs per kilo. If it's still over 30, then go to 6 mLs per kilo. If it's still over 30 at 6 mLs per kilo, go to 5, and then to 4. And then finally, if we're at 4 mLs per kilo and our plateau pressure above 30, we should switch them over to pressure controlled ventilation. But this is just saying, hey, check that plateau. If it's over 30, we decrease tidal volume, not rate. Decrease tidal volume, not rate. So here's a little picture, right? With pressure control, CMV, where the set pressure is adjusted to obtain a target tidal volume. So when we're looking at this, if they're in pressure control settings, so in volume control settings, we decrease the tidal volume, right? Or increase the tidal volume for respiratory acidosis, or increase the rate for respiratory acidosis. But what if they're in a respiratory acidosis and they're on pressure control ventilation? Well, that's what this slide's about. If they're on pressure control ventilation, then the set pressure is adjusted to obtain our tidal volume. So we can always increase the I time, right, the inspiratory time. We can always increase the I time to increase volume delivery as well without having to increase our pressure gradient. So if I make for a longer I time, right, a longer I time, this one compared to this one, right, then I have a bigger tidal volume, right? The bigger the I time in pressure control, the bigger the tidal volume. So I want to look at that and see if that's something that I can do as well besides increasing the pressure gradient. So I time is traditionally used first if the flow scaler shows a period of zero flow. So when you look up at this scaler here, here we have inspiratory and then cycles right to expiratory. Here, where this letter A is, the tidal volume is increasing, and once we have that plateau reach, that's where that is, where if we have a flow of 0 during inspirations, that's our sign that we've hit that area there. So we can use the I time first. If we see that flow scalar at 0, then we can just increase that I time a little bit more, right? So here showing another flow scalar going to 0, right? And then that's where you would adjust your I time. All right, what about a respiratory alkalosis? When the PaCO2 is decreased, right, and the pH is above 7.45, so we have an alkalosis, which means alveolar ventilation is excessive. So common causes of this, hypoxia, right? So if you're hypoxic, you're going to try to hyperventilate to support this, and that's where you'll see that initially. And that's why a lot of initial disease processes like pneumonia, those patients might actually have a respiratory alkalosis when we draw their blood gas. If it's acute, if it's early on, they might have that respiratory alkalosis, and that alkalosis is a sign that they are most likely having a hypoxic issue. So how do we fix that respiratory alkalosis in that scenario? Well, it's pretty easy. We're going to give them some oxygen. In that situation, they should slow their respiratory rate down. They should breathe a little bit more shallow, and they should come back up to a normal level once their body gets the adequate oxygen it's desiring. What about lung disease, right? Lung disease, remember the initial stages, especially with the respiratory zone there. Initial stages, these patients are going to hyperventilate as a response to the hypoxemia. Medications like xanthines, analeptics, silicates, things like that can make you go into respiratory alkalosis, make you breathe faster. Mechanical ventilation, that could be also a cause for respiratory alkalosis. If your settings are inappropriate, that could easily cause respiratory alkalosis. And even in home care patients, sometimes when they're set up for home care settings, they're not at their baseline healthy state, and by the time that their lungs start to get healthy, now their ventilation is more effective, and the ventilator now is giving them too much support compared to where they were to begin with. So that could even happen with those long-term patients. CNS disorders like meningitis, encephalitis, head traumas, those patients can easily hyperventilate. I've seen a lot of those cases in my career. And then anxiety, right? If a patient's anxious, especially if their sedation level is on the lower end, they could easily have that anxiety and hyperventilate into a respiratory alkalosis. And then finally, metabolic problems like sepsis and hepatic disease initially might cause a respiratory alkalosis, but what happens, why you don't see that a lot out there, is because when it initially happens, they're going to hyperventilate. But what happens after some time with hyperventilation, you're using all skeletal muscle, just like going out and running a marathon, right? You're going to go out and you're going to run, and then what happens to your muscles? They fatigue, right? And then that's when we usually see, okay, now they have a high metabolic rate, and the respiratory muscles fatigue. Now they're in a combined acidosis, right? So initial stages, you might see that respiratory acidosis. So in mechanically ventilated patients, hyperventilation is often the cause of respiratory alkalosis. So how do we fix this? Well, we can fix this by decreasing minute ventilation. So in volume control, we're going to decrease the rate or the tidal volume if necessary. So if we decrease the rate, but the patient's breathing over and over and over, well, we can always try to decrease that tidal volume as well. But traditionally, we try to go decrease the rate, the mandatory rate of the patient if that's doable. And sometimes, like I said, that's not doable. What if they're in pressure control? If they're in pressure control, we can decrease the rate. And if that doesn't work, we can always decrease that pressure gradient, right? Our total pressure as well. So dropping that gradient is the same as decreasing tidal volume and volume control ventilation, right? So we could decrease the pressure gradient, or in some cases, we could decrease the I time, right? And see if that helps. But how do we know? If we're decreasing pressure, how do you know that what the new PIP should be? So let's say we're in pressure control, and I want to see what my new pressure should be instead of just turning it down and hoping for the best. But this is life support. There should be a better way. There's a calculation for this, right? So that way you don't have to guess. Right, guessing and life support, I don't think those things should go together. But when you're doing this, do the calculation to find the desired tidal volume, right? So we're doing the actual over desired, right, to get to that. And then we're going to get our desired tidal volume. Then we're going to take our desired tidal volume that we're going to get, and we're going to divide it over your static compliance. So tidal volume, do it in ml. So let's say it's 500 mLs, right? And then you can divide it over your static compliance with, let's say it's 25 mLs per centimeter H2O, right? So when you're doing this, you're just going to divide it over to get that new pip that you're going to get. So the product of this would be your, or not product, the division of that would be your new pip that you would change it to. So that way you'd actually be able to calculate directly, even in pressure control, whether it's pressure control or volume control, your new tidal volume that you're changing it to. What about metabolic and spontaneous respiratory alkalosis? So if a patient's overbreathing, it can cause an alkalosis. So decreasing tidal volume in volume control ventilation, right, or PIP if we're in pressure control ventilation, we can change the patient to SIMV, where they're doing more spontaneous breathing, so that anything they trigger above that set rate is traditionally going to be just a pressure supported breath. So that could help avoid hyperventilation as well. Some patients can be very uncomfortable with that mode, so just take that lightly, or take that and then make that part of your considerations when you're switching them over. Changing them to pressure support ventilation is a method that I've seen used very commonly, very successfully, but just be aware with changing a patient to just pressure support ventilation, make sure their work of breathing is adequately supported, right? We don't want to add to that situation. And then we also want to make sure that your apnea alarms are tightly set, because if they do stop breathing for some reason or another, we need to make sure that they can still be supported adequately. All right, so sedation is an option to help with these people that are hyperventilating, but it's not the best choice, but it might have to be used in those severe cases. We try not to use a ton of sedation and alter the mental status and all that stuff that goes on. It's not our first line there. We could add dead space. We could add mechanical dead space to the patient. That is an option to retain some CO2. This could cause an increase in the work of breathing, and then you do have to remove it during weans traditionally as well. So take that one. Make sure that you're not using it as your first line of therapy, because there is some caveats that go with it, but you could always add dead space to help reduce that hyperventilation. If someone is in respiratory alkalosis, there's a drug that's a diuretic called Diamox, and that one can help with a metabolic alkalosis or respiratory alkalosis as well. So it helps, the kidneys will then start to eliminate bicarb, which would then help with the alkalosis pH altogether. If the metabolic focus, the big thing here is identifying the metabolic factors that led to that alkalosis. So treating the underlying cause is going to be something not to overlook, of course, with anything. We can treat them with the ventilator by doing these tactics here, but trying to find the cause and treat the cause is going to be the most valuable return of investment traditionally. All right, if we have a metabolic acidosis, right, that means the blood gas indicates like a pH anywhere between 7 and 7.34, right? And usually a bicarb that's lower than 22. So a lot of these patients in a metabolic acidosis will develop muscle fatigue, just trying to compensate, breathing faster. All right, and one of the classic things I think of here is a diabetic ketoacidosis that has that Kussmaul's pattern of breathing deep and rapid, deep and rapid. It's like they're doing an MVV and just rapid and deep breathing, and they're going to tire out, right? They're trying to compensate, and then eventually they tire out. So how do we avoid this patient? Even though their PaCO2s might be in the 30s or lower, we might need to put them on non-invasive ventilation or even mechanical ventilation to avoid that fatigue that's going to set in. So that actually might be an indication to intubate in some of those patients. But what are some causes of this, right? Ketoacidosis is the one that I brought up with with diabetics, but you can also see that with starvation and alcoholism. Uremic acidosis, you'll see these with renal failure patients where they're starting to excrete acid. So your renal failure patients easily an acidosis. Patients that have a massive loss of bicarb like diarrhea can easily go into this metabolic acidosis. Renal loss after administration of carbonic anhydrase inhibitors or Diamox, which we talked about already. For the alkalosis, well, if we give Diamox, we could lose that base. Like I said before, it gets rid of a base with your kidneys, and so it actually could end up causing a metabolic acidosis if we do it a little too much. What if we have a lactic acidosis, like what we see with athletes or people that are in severe infections, right? And even toxins like silicate poisoning, ethylene glycol, like antifreeze, methanol, those things can cause that metabolic acidosis as well. So is this an addition of an acid or a loss of a base? How do I know? Well, that's where you do the gap equation, right? Your sodium and potassium plus, right? Sodium plus potassium minus your chloride and bicarb gives me my anion gap. And if it's greater than 16, then I know it's the addition of an acid compared to the loss of a base, like the diarrhea there, right? Or the Diamox administration. So that can actually help me determine what the cause is, and then we can always work the cause as a team. So how do we treat a metabolic acidosis? Well, addressing the cause is what I just said, right? We need to find that cause and treat it. Possible administration of an alkalizing agent. So two big ones would be sodium bicarb, and then the other one would be THAM. THAM is an enzyme that doesn't increase your CO2, however, sodium bicarb does. So we have to look at that and make sure that it's an appropriate agent that we're giving the patient and that they would respond to it. And it's controversial. Treating the underlying cause, like giving them vascular volume or inotropes if they're metabolically dry, right? That could easily help the patient. Adequate oxygenation. The key here is to buy time for the metabolism of organic acids and the kidneys to generate bicarb to replace any losses that happen. So the key here, buy time. Right, buy time until we can get those things up and running. Some things that we can look at is giving them bicarb, but however, if you give someone bicarb, right? So we're going this way. You give someone bicarb, it goes to carbonic acid, and then it disassociates to water and CO2. So what happens with their CO2 production? Well, their CO2 production increases, and so they'll have a transient increase in their CO2s, which even though their pH looks better, their CO2 at the cellular level is worse, and that could even cause more issues with oxygenation and their metabolic acidosis. So it's controversial. And so you see people, some providers may not give it till their pH is 7.0 or less. What about a metabolic alkalosis? Well, usually this means that the pH is greater than 7.45 and the bicarb's over 26, right? So some causes, loss of gastric fluid, so they've been suctioning the stomach juices out, or the patient was vomiting. If they lost an acid in the urine, like they gave them a lot of diuretics, right? So that could cause someone to go into an alkalosis. If someone's hypokalemic, right? So that can easily be a cause. The lactate, acetate, or citrate administration, so we're giving them those, and that can easily cause an alkalosis. Or if we give them too much bicarb, all right? If we give them too much sodium bicarb administration, that could easily send them the other direction into a metabolic alkalosis. So how do we treat the metabolic alkalosis? Well, treat the reversing factor. Treat the cause and reverse the factors. If it's severe enough, we can use carbonic anhydrase inhibitors, which is an antihypertensive medicine, and that can help with that. We can also give them acids to infuse, low bicarb dialysis to pull it off as well. And then finally, hypoventilation can cause deoxygenation. So if the plan is to hypoventilate to retain some CO2, like adding dead space, be careful because this could stimulate the chemoreceptors in the brain to increase minute ventilation, which says to increase your rate and tidal volume, and that would be the opposite of what you need because then they would go into a respiratory alkalosis on top of being in a metabolic alkalosis. So be careful with this whole hypoventilation or adding dead space thing there because that could actually stimulate them if you don't have the proper oxygenation to have their minute ventilation go up. So be careful. What about dead space? So if pure respiratory acidosis persists, even after we have increased alveolar ventilation, then the problem is actually dead space. So let's say, Derek, tell me what this means. All right, so here's a scenario, right? You go into a room, someone's in a respiratory acidosis on the ventilator, and you increase their minute ventilation, right? Whether it's tidal volume or rate, right? You go and increase that, and then you draw another gas. But they still have the respiratory acidosis, even after you just increase their alveolar ventilation, right? You know that there's more alveolar ventilation, but why? Why did their CO2 not go down? Well, it's probably because of dead space. So this could be an issue that's caused by a process like pulmonary emboli, where there's reduced blood flow, or low cardiac output, which is reduced blood flow, or high PEEP levels, which squishes the capillaries and reduces blood flow, or air trapping, which hyperexpands the alveoli and reduces capillary blood flow, right? Or even uneven ventilation, right? Which reduces blood flow to different alveoli. So do you see a theme here? Dead space means you're ventilating, but you're not perfusing. So something there has reduced blood flow. So if we've increased minute ventilation and our CO2s aren't staying the same, then that's a sign we probably have a dead space issue. So we need to figure out the cause. Well, what's going on with their blood pressure? What's going on with their cardiac output? Are the PEEP levels now too high, right? Is there air trapping? Is there uneven ventilation going on? Sometimes little changes like putting a diseased lung up to reduce perfusion, so it's the opposite of being dependent, right? So let's say the left lung is diseased, you put the right lung dependent, the left lung up in the air, right? In theory, that could help because then you're putting perfusion to the good lung and taking away perfusion from the bad lung, right, in that situation. So we can try to help that. Pulmonary embolism would obviously be trying to treat the pulmonary embolism, blood thinners, taking it out. Low cardiac output, positive inotropes, vascular pressors, things like that. High PEEP levels, turning the PEEP down, and air trapping, fixing the air trapping. Those are all things that we could easily do to help with those dead space processes. So with the dead space process, we can actually quantify this instead of guess. How bad is this dead space? Well, I don't know. All I know is that the rate change or the tidal volume change really didn't change their CO2. How am I supposed to know how bad it is? Well, there's an equation for this, right, that help you quantify that. It's called the dead space to tidal volume ratio. So the dead space to tidal volume ratio, normal is 0.2 to 0.4. But when we start getting really sick, right, those are patients usually greater than 0.6, 0.7. So how do I do this calculation, Derek? Well, this is easy. You're going to get exhaled CO2 levels and a blood gas. So you're going to put the patient on exhaled CO2, whether they're intubated or not, right? Put an end tidal CO2 on them, right? And then you're going to do this equation. This is the modified Bohr equation. So it's the Paco one of my favorite ones. And it's going to tell you your dead space to tidal volume ratio. The bigger the number, the worse their dead space is. So the gradient between the dead space is one of the easy ways to look at this without calculating it, although it's not a very complicated calculation. A normal gradient from PaCO2 to end tidal CO2 is about 4 to 6 millimeters of mercury. So whenever we see this gradient increased, we know their dead space is also increased. So if you're looking at a patient and they're on end tidal CO2 on the ventilator and you know what their blood gas is, that's where you can just compare the two. If the gradient keeps getting bigger and bigger and bigger, even though you've gone up on your PEEP, you've gone up on your tidal volume, you've gone up on your rate, what happened to the possibility of overdistending their lungs? It's there, and you might be actually causing a dead space problem, and might be why their oxygenation is worse, why their acidosis is worse. So in that situation, you might need to go down on your airway pressures to reduce that overdistension, to allow them proper capillary perfusion, or possibly give them fluids to help with a better perfusion to their lungs. All right, what about metabolism, right? We talked about metabolism a little bit. If you have an increased metabolism, you're going to have an increased CO2 production, right? That's what it's doing. It's consuming oxygen and pooping CO2, right? So the more your oxygen you're consuming, the more CO2 you'll be producing, right? So what increases your metabolic rate? Well, we've already talked a little bit about this: fever, burns, trauma, sepsis, hyperthyroidism, tremors, seizures, an agitated patient, or even surgical procedures that cause trauma to the patient. So the big thing here is these things will increase the need for minute ventilation. But when this patient's breathing fast and deep because now they're running a massive fever, or they're agitated and their sedation wore off, or their body's just going through a lot of surgical procedures and they're in a sympathetic state, then we know that they can breathe faster. So that's going to cause them to breathe faster. So one of the things that we can do is allow them to breathe faster, support that. But you got to watch out for this. Watch out for that air trapping if they're breathing faster. Right, air trapping and breathing faster are not friends. So if they're air trapping and breathing faster, we need to make appropriate ventilator adjustments to reduce that air trapping. Okay, I hear this thing about hyperventilating patients with high intracranial pressures. I remember this when I was in school way back when. This was a standard of practice type thing then. But now, notice the word historically. Notice I put the word historically there. And the book put it there too, right? It's not just me, right? Hyperventilation was used in acute head injury patients that had high intracranial pressures. The thought is that it lowers the CO2 in the blood and will cause constriction of the cerebral blood vessels and reducing blood flow to the brain, which in theory would help decrease their ICP. So the guidelines for head injuries with increased ICP do not, notice I made that bold, do not recommend prophylactic hyperventilation. So that means CO2 is less than 25 during the first 24 hours. So they don't recommend that anymore. Hyperventilation may actually increase cerebral ischemia. So if you vasoconstrict those blood vessels, how much blood flow is going to the brain itself? Not much. How much oxygen is going to the brain? Not much. Does that sound like that's a good thing, depriving the brain of oxygen? Anyone? Is that a good thing, depriving the brain of oxygen? Yeah. So that's where they're like, hey, this isn't great. So it can be used for brief periods with neurological deterioration. Their ICPs are going through the roof. Can you use it? Yes. However, what's the risk of it? Well, anoxic brain injury, ischemia of the brain, those things. So that's why it's more in that historical aspect there to use that CO2 less than 25 technique. What about mild hyperventilation? Okay, so if I can't do a CO2 less than 25, what about a CO2 of 30 to 35? Well, this can be used for longer periods with increased ICPs that are refractory to treatment. So this is not your first line of therapy, right? You're like, oh, hey, I can do something for my aspect. Yes, you can, but only after these fail, like sedation, putting them on a paralytic, draining the cerebral spinal fluid, or doing hyperosmolar therapy, right? So after those things, then you can pull that card out of your toolbox and see what they think about it. But until then, we're going to use those tools, right? This is the last tool in the toolbox, is to take that CO2 to 30 to 35 range level out. So iatrogenic hyperventilation is debatable because the effects associated with reduced blood flow to the brain, and that results in brain ischemia, right? So that's the big thing here. So you're like, hey, this sounds like a great thing. It's easy to do. It's free. It's immediate. But I want you to see that whole cerebral ischemia component and think, no, that's a pretty big downside. But it's something we can do in just emergent, short-term situations. But that is not something that we should do routinely, because ischemia to the brain, not a great idea. All right, so now we're talking about permissive hypercarbia or permissive hypercapnia. So this is where we're starting to see the patient's lungs get worse and worse, right? So occasionally it's impossible to get a normal CO2 level out of a patient without causing their plateau pressure to be above 30. So if we're already having issues having a plateau pressure above 30, we need to turn down our volumes. We need to turn down our volumes. We need to keep going down. The plateau pressure of 30 tells us about alveolar pressure, and we don't want to exceed alveolar pressures of 30, right? So where does this traditionally happen where we see these high plateau pressures? Well, that's most common with our lung diseases like status asthmaticus, COPD patients, or even your ARDS syndromes, which ARDS can be caused by many things, including sepsis. So those are the patients that we're traditionally using permissive hypercapnia on. So hypercapnia means their CO2 levels are allowed to rise. Hypercapnia, right? So permissive hypercapnia and hypercarbia is the opposite of hyperventilation, right? It's hypoventilation on purpose. And the whole thing here is to avoid ventilator-induced lung injury, or a VILI, right? Ventilator-induced lung injury. If we can avoid a VILI, that's the idea, because what happens if our plateau pressures are above 30, right? Bad settings result in activating inflammatory mediators that lead to multi-system organ failure. Multi-system organ failure. So, if that plateau pressures remain high and we're causing ventilator-induced lung injury, you can actually cause more than ventilator-induced lung injury. You can actually cause your patient to lead to multi-organ system failure. So that's going to be one of the things that we'll have to look at there. That's why we need to let their CO2 levels rise. So this avoids overdistension on purpose, right? We're going to start to turn down their tidal volumes, and we're going to target a pH that's 725 or above, or 720 and above, depending which study they go by. But the CO2 is allowed to increase in increments, usually up to around 80 millimeters of mercury, and sometimes more than that, depending how sick their lungs are. But remember, when we're doing this, when we do permissive hypercarbia, we got to go slow. It's around 10 millimeters of mercury rise in CO2 per hour, and then at most you want to allow it to go up to 80 traditionally, and we can go above that, but we're going to try to go slow with this because it'll cause the patient to breathe faster traditionally, so we got to do it and titrate it slowly. So as CO2 increases, there is a decrease in PaO2, right? So be considerate. If we're decreasing our minute ventilation, what happens to our CO2? It goes up. Well, is there as many parking spaces available for the oxygen? No. So there's going to be a decrease in their ability to carry oxygen because of this technique. So this can cause a right shift of the oxyhemoglobin dissociation curve. You're like, okay, that's cute. What does that mean to me, right? What does that mean to you? Well, that means that since we're unable to carry as much oxygen on our hemoglobin, we're going to have higher oxygen in our plasma, so your PaO2 becomes very important. Because the CO2 is going to be occupying a lot of parking spaces on the hemoglobin. Well, how are we going to get oxygen in there? Well, we got to get the PO2. Right, PO2. So you need to make sure that their PO2 traditionally is 55 or more, 55 millimeters of mercury or more, to help them get the appropriate oxygen delivery. So once that PO2 goes in there, and whatever oxygen is on the hemoglobin, unloading is increased. Unloading of oxygen is increased at the tissue because the right shift refuses oxygen. It'll hold on to CO2 and it'll refuse oxygen. So unloading of oxygen at the tissue, it will do that. It will refuse it and get rid of it at the tissue. But the level of oxygen loading at the lungs is decreased. So, are we going to be able to carry a lot of oxygen to the tissues to get it there to drop it off? No, we're not going to be able to carry a lot of oxygen. Whatever oxygen does get on some hemoglobin, it's going to get rid of it really quickly. But our ability to carry it there or to deliver it there decreases. So this is where it becomes very important to optimize PaO2, P little AO2 as well, right? We're going to try to get that up. So how else does your body respond when you start putting someone in permissive hypercarbia? Well, the other thing that you're going to do if your CaO2 decreases, right, because your saturation decreases, then your body's going to try to compensate to deliver more oxygen to the tissues by increasing the cardiac output, right? So that's something you have to worry about with this strategy is, do they have a strong cardiovascular system? If they have a weak cardiovascular system, like if they're in heart failure, permissive hypercarbia could actually cause their heart failure to be worse, right? It could cause them to work harder because traditionally they're going to try to compensate by increasing their blood pressure, by increasing their cardiac output. So be aware of that type of situation. So because of their CO2 is now high, it triggers the brainstem, and we have to use a deeper sedation or possibly put this patient on a neuromuscular blockade agent like a Nimbex drip or a paralytic drip of some sort. So when we're seeing their CO2 start to rise, that's where we have to be careful. We might have to go deeper into sedation or even paralytics on these patients with permissive hypercarbia to help out. It's not comfortable having a high CO2, and the brainstem agrees, and so that's where we might have to reduce that response. But when our CO2s are greater than 200, this can even result in an anesthesia effect known as CO2 narcosis. So we can see that effect as CO2 increases, their ability to respond to things decreases as well. Hopefully we don't have to go to a CO2 over 200, but that's what you're looking at. So things that we're looking at when we do this, when we're implementing permissive hypercarbia, we need to remove the sources of any dead space at all, as much as we can to help with their dead space to tidal volume ratio. And increasing the rate of mandatory breaths might have to be done just to make sure their pH stays somewhat stable, because we're turning down tidal volume. So we might have to increase frequency to help make up for it, but once again, our VDVT is going to go up. So increasing the CO2 by 10 millimeters of mercury an hour to a max of 80 per day is what we're going to look at. So it's that slow increase of CO2 retention over time that could help the brainstem acclimatize to that a little bit more effectively. FiO2, we're just going to titrate that to get anywhere between 85 to 90, right? Anywhere in that range. That's what we're shooting for. Using permissive hypercarbia for more than 24 hours, you might need to use a large buffer. In some cases, if you're using it for more than 24 hours and you're on a lot of buffer, you might have to discontinue this strategy just slowly over a couple days, around 2 to 3 days as well. So that's something to consider if we're on a bicarb drip or THAM or any of those other neutralizing drips. That might be an indication to change them over. Neuromuscular blockades can be used during this. I've seen that quite a bit to reduce CO2 production. They decrease oxygen consumption and they lower your peak airway pressures too. So that can help as well. So there's a number of advantages there to using a neuromuscular blockade agent. But however, to do that, we need to paralyze them. Otherwise they'll shiver, right? So they're paralyzed for neuromuscular blockade. We're paralyzing them, and then we're going to make sure they have deep sedation, because it's cruel to be paralyzed but fully aware, right? So we're going to have to make sure they're under deep sedation. So both of those, both paralytics and deep sedation, can have a lot of neurologic and physical side effects. How well is that patient's diaphragm? When we're done with this technique, how strong is their diaphragm going to be to wean off of that ventilator, right? How much ICU delirium could we possibly see out of that situation? So that's something that we're going to have to look at and hope that we can mitigate that down the road. But in the meantime, we need to make sure they survive till that point as well. Cooling, right? This is where this may require NMBA as well, because cooling, when we cool patients, they can shiver, right? And that's where my brain was going earlier. So when we cool people, we may have to use a neuromuscular blockade. That cooling will restrict glucose, and then it can reduce CO2 production, which then helps control that CO2, so we have better oxygenation as well. So if we decrease CO2 production, we might be able to carry more oxygen to the tissues and actually have less lactic acidosis or less issues there. So what are some contraindications of permissive hypercarbia? Well, just remember the CO2 is a vasodilator. Sorry, CO2 is a vasodilator of the cerebral vessels. So if we retain CO2, we'll dilate the blood vessels in the brain. Just like we talked about with hyperventilation, it constricts the blood vessels in the brain and causes ischemia. This one, if we retain CO2, it'll cause vasodilation of the cerebral vessels, and you could get cerebral edema and increase your intracranial pressure. So if you have someone that has a cerebral trauma or hemorrhage, cerebral hemorrhage or cerebral lesions or any head trauma at all, this might not be a good patient to do permissive hypercarbia on. If they have previous existing cardiovascular instability, this might not be the best patient to put this on, because it tells the cardiac output, hey, you're not delivering as much oxygen. I need to increase the squeeze of the heart. Well, if the heart's already weak to begin with, how well is that going to work, right? So if they have low myocardial contractility, so they have left ventricular failure, arrhythmias already, or if they're on vasodilation medications, that might not be the right patient, because that could drop their blood pressure or they can send their heart into failure. So use permissive hypercarbia with a caution on your cardiovascular patients. So if they have cardiac ischemia or poor left ventricular function or pulmonary hypertension, cor pulmonale, those patients, you need to be very careful, because that could be detrimental to their care.